All right, now we're going to talk about the nervous system. In this section, we're going to talk about the nervous system and the musculoskeletal system. Uh, the nervous system is made up of different parts. We've got the central nervous system, which is the brain and your spinal cord. We've got the peripheral nervous system, which is everything outside of that. We've got sensory nerves, which get incoming information. We've got motor nerves, which take up outgoing information. So, like sensory nerves, let's say you notice it's cold. You want to put on a jacket. Your sensory nerves pick up that sensation of cold, and then your brain processes that, hey, I'm cold, I need a jacket, and you go get a jacket. The process of you getting up to go get the jacket is taken care of by your motor nerves. Motors means motion. So sensory is sensing something. Motor means going and doing it. All of our sensory information is incoming information. Our sense of smell, our sense of taste, our sense of hearing. Notice the word sense. All goes to our brain. Our brain processes it and then sends out a signal saying, hey, go do this, go do that. That's motor that's responsible for that. So we have two kinds of nerves. We have sensory nerves and we have motor nerves. If you look over here at this little picture, this is what's called typically a neuron. This is a nerve cell. Now, this little part right here is kind of cut in half to show you that these things can be very, very long. The nerves in your big toe, if you follow the line back, goes the whole way back to your brain. So if you're 6 foot tall, the nerves to your big toe are 5 3/4 feet tall, long. They're long because they're all carrying information. So when you stub your toe, this little part right down here, which is the nerve endings, get a sensation, ow, that hurt. It goes up to your brain the whole way through your body to that nerve cell and to the cell body, and that dendrite attaches to other nerve cells. These are called our synapses, and these synapses are where we gain knowledge, we learn things. So your brain says, ouch, that hurt. Well, the reason you know it hurt is because these dendrites are attached to another brain cell that says that's what pain feels like. Then finally, we've got axons. These little things are called myelin sheaths. They're basically fat insulators. Well, basically, your nerves are biological wires. They carry electrical signals. They have to be insulated, otherwise they'll short circuit. And in our body, we insulate with fat. All right, so it's important to have fat in your diet because that's how your nerve stuff is made. As a matter of fact, about 90% of your brain is actually made of cholesterol, which is a form of fat. So if somebody calls you a fathead, you just tell them, thank you. I knew I was smart. All right, the autonomic nervous system runs parallel to the peripheral nervous system. The peripheral nervous system is the outgoing system. That's everything coming out of the spinal cord. The autonomic system is not protected in the spinal cord. It runs on the outside of the spinal cord. It has impulses to inhibit or stimulate certain activities. The autonomic nervous system many times affects our feeling. It's affected through our feelings and emotions. It's affected through our subconscious, but it affects our heart, our blood vessels, digestive tract, liver, spleen, kidneys. Everything that you can't consciously move is affected by the autonomic nervous system. We'll talk about that in a little bit. Now, this is a drawing to help you understand the central and peripheral nervous system a little better. Central is going to be the brain. Going to be that guy right there. Sorry, that's not a very good circle. And then the spinal cord. Nor is it a straight line, but you get the point. The peripheral nervous system is going to be everything coming out of that central nervous system. All right, and everywhere it goes. All right, so that's the central nervous system versus the peripheral nervous system. Important thing to remember, central nervous system is the brain and the spinal cord. All right, now the autonomic nervous system. The autonomic nervous system is broken down into two parts, and you can call it the fight and excite, and the rest and relax. All right. The parasympathetic would be the fight and excite. You think about it, if you've ever been excited for something, how did you feel? That's because of the parasympathetic nervous system. We can do things to our brain to get ourselves hyped up, but can I automatically hype myself up? And the answer is no. That is the sympathetic nervous system we're talking about. I'm sorry. That's the fight and excite. This is the rest and relax. All right. Sympathetic is the fight and excite. Different things that happen to you. Your pupils get dilated. Your mouth gets dry. Your heartbeat accelerates. Your bronchi dilate. They get bigger. Your stomach quits working. Conversion of glycogen to glucose. You start making glucose. You're ready to burn energy quick. You begin to secrete adrenaline. Your bladder quits contracting. If you ever think about how you get ready for a game, that's a sympathetic nervous system at work. If you ever something else you're excited, you're asking a girl out on a date, asking a boy out on a date. This same thing's happening to you. Your mouth gets dry, you kind of heartbeat speeds up a little bit, you might become a little bit clumsy. That is all the sympathetic nervous system. Now, that is not affected by your spinal cord. It all is affected by this nerve right here called the vagus nerve. The vagus nerve is probably one of the most important nerves in your body that a lot of people don't know even exists. If you've ever wondered how somebody can be a paraplegic but can still live, it's because of the vagus nerve. As long as I'm not too high, I can completely sever the spinal cord, like right here. You see where the vagus nerve comes out if you follow it up. If I cut the spinal cord right there, that person may not have any use of their arms or their legs. It's called a quadriplegic. But because they didn't cut it above where the vagus nerve comes out, they still can have a heartbeat, they can still breathe, they can still digest, they can still use the bathroom. They might not have much control over your bladder because bladder is a lot of manual stuff, not always, or a lot of peripheral nervous system stuff. It's not, we control when we urinate. But animals really can't unless you house train them. You watch a cow, he pees when he wants. All right. And then parasympathetic, that's the rest and relax. Think about when you fall asleep. Think about somebody falls asleep in class and everybody laughs at them. What do? They drool all over their desk, right? It's because the parasympathetic is active and their saliva is beginning to flow, heartbeat slowing. They're not breathing. They start that deep rhythmic breathing. You hear their stomach growling because they're digesting at that point, and their bladder starts to squeeze. Might have to get up and go use the restroom. So that's the difference between the parasympathetic nervous system and the sympathetic nervous system. But they are important point to take home from that is they're affected by the vagus nerve, not through the spinal cord. All right, now here's a question. How do we evaluate the central nervous system? There's a couple things we check. We check pupillary reaction. If somebody's central nervous system is affected, their pupils may not be doing what they're supposed to be doing. A normal person's pupils, when you turn the lights out, their pupils get bigger. When you shine a light in them, they get smaller. Somebody with a central nervous system problem, their pupils might not be reactive. Their pupils might be different sizes. Different sizes is bad. That usually means a brain injury. They might be slow. In general, constricted pupils don't mean a whole lot unless you suspect a drug overdose. And sometimes when people have seizures, they have pupillary reaction. But in general, what we're more worried about is pupils that are really, really large, because that means that the body's lost control of the diameter of their pupils, and it's basically shut down the sensory information they're getting from the eyes, so it doesn't matter how much light they're getting. We want to look to see if there's cerebrospinal fluid leaking from their nose or their ear. Cerebrospinal fluid is a clear substance. It has a little bit of a yellow tinge to it. If you're seeing fluid coming out of their nose or their ear, that could indicate a skull fracture, and that could indicate that the central nervous system in its encased cavity there has been interrupted. It means there's a fracture somewhere. It's leaking fluid out. That's usually a bad sign. That's a sign that there could be some kind of central nervous system involved. If they can talk, their memory might be affected. They might have problems with their long-term memory. How do we check that? Ask them questions that they should know and that you know the answer to as well. We don't want to ask them what'd you have for breakfast, because they can lie, because you have no idea what they had for breakfast. Ask them who the president is. Ask them who their principal is. Ask them what team they're playing. Ask them what kind of car they drive. Ask them long-term memory questions. Short-term memory is easy to evaluate. We actually have them remember some numbers or words, or have them repeat them back to us. Uh, if they can't remember them, then their short-term memory might be affected. We want to look at their visual and verbal processing. Can they read something? When they're speaking, does it make sense? Or are they just throwing out words that don't make any sense? We want to look at their ocular tracking. We want to look and see if their pupils and their eyes can follow like a light or a point. Uh, One of the other things that can happen with a central nervous system injury is if you go over into their peripheral vision rather than right in front of their eyes, but over on the side when they're falling, their eyes might tick back and forth. That's called a nystagmus. Nystagmus is always a sign of some kind of mental impairment. All right, so how to evaluate that peripheral nervous system? We check for nerves, or we check for motor and sensation. Can they move an extremity? Can they move their foot? Can they move their hand? And do they feel it? And do they feel the same on both sides? It's important to check on both sides, because something a lot of people forget is in a human brain, this is the patient's right side. The patient's right side controls the left part of the brain, left part of the body. Patient's left side controls the right part of the body. So all these dermatomes over here, which is the place where skin sensation takes place, is actually being controlled by this side of their brain. So we need to check their upper extremity, lower extremity sensation. If you look at this picture here, we've got in the spine, we've got the cervical spine, which is C, indicated here through C. There's 8 cervical vertebrae. Then we have the thoracic. There's 12 thoracic vertebrae. And then we have lumbar, which is 1 through 5. And then sacral is actually 5 different vertebrae, even though most people they fuse into one. Every single space between these bones has a nerve coming out. And the nerves, you can kind of look at the key in this picture. The cervical nerves are the back of the arm and the neck. Thoracic nerves are the front of the chest and the back of the chest. Lumbar are the legs. And then finally, the sacral is down there around the back part of the legs and really your butt cheeks. So if they're having diminished sensation, we can, in that area, we can suspect that there might be some kind of a nerve involvement, especially if they complain about numbness or tingling. All right, the Glasgow Coma Scale. Glasgow Coma Scale is a universal way to evaluate central nervous system condition and if you understand the Glasgow Coma Scale, you can better explain to the responding units what kind of level of consciousness your patient has. So I'm going to have to minimize this just a hair. All right, there you can see it. We're going to look at the child side here. First thing we do is talk to the patient. One thing that's very important to remember about the Glasgow Coma Scale: there is no such thing as a score of 0 on a Glasgow Coma Scale. And I'll show you why in a minute. You tell somebody they have a Glasgow Coma Scale of 0, whoever's responding is going to be like, you don't know what you're talking about. All right? So first thing we do is we check eye opening. If we arrive on scene and they're looking at us, they have a 4 for spontaneous eye opening. If they have their eyes closed, but when you talk to them, that's what to-speech means, they have a 3. If we try talking to them and nothing happens with their eyes, we can actually pinch them between their thumb and their forefinger in that fatty part on their hand and see if they respond to pain, if they moan, if they try to pull away, if they do something. The other thing we can do is a sternal rub, which some of y'all know what that is, to see if they're responsive. If they don't respond to any of those things, they've got a 1, which means they're no response. All right, so let's say they are talking. They know where they're at. They know their grandma. They know Donald Trump's president. And they know everything they need. They're oriented, and they've got a 5. If they kind of know what's going on, but they're confused, they're not sure exactly what's going on, they may have a 4. If you ask them who's the president and they say potato chip, they're using inappropriate words. Or they're getting words out, but they don't make any sense. That's inappropriate. If they get something that just sounds like a mumble, those are what are called incomprehensible, and that would get them a 2. No response would be a 1. You try and get them to talk, and they just stare at you. That's a 1. All right. Obeys commands. Motor response. If they obey commands, they get a 6. All right. If they can do what is required of them, they get a 6. If they localize pain or withdraw from pain, they're going to get a 5 or a 4. Localized pain means they kind of grab at the area where you're causing that painful response. Withdraws from pain means they're trying to pull away. That's going to give them a 5 and a 4. Now, decorticate and Deceibrid position, which is flexing and extension, they're pointing their toes or they're curling up. And I'll show you a picture of that in a minute. And then finally, no response is a 1. So if somebody that's really, really bad basically has a Glasgow Coma scale of 3, look at something around you at the room, something like a lamp. A lamp has a Glasgow Coma scale of 3. Because if you tell the lamp to open its eyes, you're not going to get a response. You try and get the lamp to talk to you, you're not going to get a response. And you tell the lamp to move, you're not going to get a response. So you get a Glasgow Coma scale of 3. If the lamp was a real person, we would want to intubate that patient. It means we're going to give them a specialized airway. Somebody with a Glasgow Coma scale of 3 probably needs CPR. So that's how we evaluate the Glasgow Coma scale. All right, so I want to show you posturing here now. All right, if you arrive on scene and you notice the patient's toes are pointing and their hands are flexing and they're straight out like a board, that is called Deceibrid posturing. Or you arrive on scene and they're curled up, their wrists and hands are curled up into their chest, their toes are pointed. That's decorticate positioning. Those indicate major cerebral problems, all right? If it looks like they're kind of frowning, that's another way. If you're seeing this, I don't care what their Glasgow Coma scale is. This person has a major problem in their brain, and you need to alert incoming units that there's potential head injury. All right, the skeletal system. Now, we're going to go through the skeletal system really, really quick because there's not a lot to tell you. You can learn. I want you to learn these bones and these muscles because the more you know them, the better off you're going to be. So it might be worth taking some time and learning these things. The skull is your head bone. Your sternum is your chest plate. That's surrounded by the ribs. The scapula and the clavicle are the shoulder bones. Then we have the humerus, which is the upper arm bone. Radius and ulna are the other bones in the wrist. Carpals are the wrist bones. Metacarpals are the hand bones. Phalanges are the end. If you notice in both the toes and the hand, the phalanges are the little bones on the end. In the foot, we have tarsals. Tarsals are the large bones in the ankle. Metatarsals are the large bones in the foot. All right. Way I keep carpals and tarsals separate in my brain is I have a little hint. North Carolina's mascot is the Tar Heels. Tar Heels to me sounds like tarsals. So that's how I remember tarsals from carpals. Carpals, when I wave at somebody and I'm in carpool, I use my carpals. All right, we've got the hip bones here. The sacrum is the bottom of the spinal cord. The femur is the largest, strongest bone in your body. Patella is the kneecap. The tibia and the fibula are the 2 bones that bear weight in our body. There's an example of the spine. We already talked a little bit about it. It's made up of many multi-segmented bones. They're separated on the inside between discs, which are broad, fat bands of cartilage. All right, now in our body, we have three different kinds of muscle. We have smooth muscle, we have cardiac muscle, and we have skeletal muscle. Smooth muscle is involuntary muscle. We cannot control involuntary muscle. It does what it wants to do. It lines the stomach, the bladder, all of our organs are lined with involuntary muscle. We cannot directly affect that. I can't sit here and say, all right, stomach, quit digesting. But going back to that nervous system, the autonomic nervous system, we can affect it. If you ever felt really, really bad after breaking up with your boyfriend or your girlfriend and you just didn't feel like eating, your sad state was actually affecting your involuntary muscle. It moves stuff, this involuntary muscle moves stuff along through the system, and it moves it at different rates. Depends on how much you need to absorb. Cardiac muscle is also an involuntary muscle. There's nobody can concentrate hard enough to make their heart stop. And it contracts and relaxes to pump blood through the body. Cardiac muscle is an interesting kind of muscle. It's actually a hybrid of smooth and skeletal muscle. It's smooth in that it cannot be controlled voluntarily, but it's strong like skeletal muscle. But one of the other interesting things about heart muscle, because it's a hybrid of the two, it actually cannot catch a cramp. When it gets to the end of its maximal contraction, it automatically releases. So that's one of the cool things about cardiac muscle. Skeletal muscle is contained in the muscles and moves the skeletal system. It contracts and relaxes for a coordinated movement. These are some different large muscle groups, some that you need to know. The deltoids are in the shoulder. The trapezius muscle is that muscle that runs from the shoulder to your neck. We have small muscles in our back called erector spinae that allow us to sit up straight. Triceps is the back of our arm. Latissimus dorsi is the big muscles in our back. The gluteus medius and maximus are in our butt. That's your butt muscle. That's your glutes. We've got the abductors and the adductors. The abductors are the outer thigh muscles. The adductors are the inner thigh muscles. Hamstrings are the large muscles that run up and down the back of the leg. The gastroc is our calf muscle, and it's actually a two muscle. It's got the gastroc and the soleus joined together. Looking at the front, there's the deltoid again. We've got the biceps, which is the make a muscle. Pectoralis muscles, which are our chest muscles. Our abdomen is made up of three different layers of muscle. We've got the rectus abdominis, the internal obliques, and the lateral obliques. So it's 3 layers of muscle. The quadriceps are large muscles on the front of the thigh. And down there in the front, we have muscles that actually allow us to lift our toes. Another view from the side. So how do we evaluate the musculoskeletal system? It's pretty simple. We use this mnemonic called DOTS. DOTS stands for deformity, open injuries, tenderness, and swelling. You can only evaluate the musculoskeletal system by putting your hands on the patient. You have to touch them. It's called palpation. Put on a pair of gloves and you have to touch them. We're looking for deformity, looking for those open injuries. What's an open injury? Something where a bone broke the skin, or they're complaining of pain and there's a laceration there. A point where it's tender, it hurts when you push, and you're looking to see if you can see swelling or feel swelling. The other thing that we can evaluate by using DOTS during the quick head-to-toe evaluation, we can evaluate the skin. We can evaluate the skin condition, the color, temperature. We can look for abrasions, look for injuries to the skin. And we can also evaluate the nervous system by doing checking the cerebrospinal fluid, pupillary reaction, eye tracking, motor sensation, memory, and visual and verbal processing. We can evaluate all this stuff while doing this rapid trauma assessment, which is something we'll learn a little bit more about later. All right, we're going to pause it there, and then we're going to move on to the next section.